So next up, we have Victor Huynh and Marcus Sanzi, representing AIDS Vancouver. So Victor grew up here in Vancouver, BC. He has previously worked in the south of India to help successfully secure bilateral agreements protecting the rights of Indian migrant workers in Gulf nations. This led him to complete a Master's of Social Work degree at Ryerson University in Toronto, where he continued to focus his work on marginalized communities, particularly with queer men of color. While working at Casey House, the HIV hospice and supportive care hospital in Toronto, he further developed his understanding of sexuality and race as major intersecting factors of identity impacting access to space, knowledge, and health. This ultimately led him to join the HIV prevention-oriented health promotion case management program, working with other men who have sex with men at AIDS Vancouver. And Marcus graduated from his BA in psychology and specialization in psychosomatic medicine at Faculty of Health Science at the University of São Paulo, Brazil, where he also worked at the Hospital of Faculty of Medicine at the University of São Paulo, especially with LGBTQ/HIV prevention. He also joined the HIV prevention team this year as the health promotion case manager working with gay and bisexual men at AIDS Vancouver. Marcus is a student member of the Canadian Counseling and Psychotherapy Association. And so today they're going to be sharing with us stigma and discrimination within the queer men's community and how it prevents access to supportive care.
Thanks. So Marcus and myself today was just going to give a presentation about stigma and discrimination as a barrier for MSN to access supportive care. So last year at the summit here, we were just kind of giving an introduction to the health promotion case management program, and this year we're hoping to give you some updates about what we're seeing and why we're seeing it. So the health promotion case, so we're just going to give you a brief background about the health promotion case management program, what we're seeing in our programs, and Marcus will provide a brief case study about what we're seeing, and we'll discuss why we're seeing it and the issue of hierarchy as the main issue of stigma that creates barriers to supportive care. It'll kind of be the focus of the presentation, and we'll conclude with what's currently being done to address stigma and what more needs to be done. So the health promotion case management program is an intensive case management approach to HIV prevention. So 7 case managers are hosted at 5 organizations working with 10 key populations identified as being high risk for HIV. So at AIDS Vancouver, Marcus works with gay and bi men, and myself working with other men who have sex with men, men in zero and discordant relationships, and the trans community. At YouthCo, Navi works with vulnerable youth, and including some of their families. And Settlement Orientation Services, Byron Figueroa works with immigrants and refugees. And at the Inner City Women's Initiative Society, Liz and Kate are working with vulnerable women. And at Native Court Workers, they work with Native Court Workers Counseling Association of BC. They work with First Nations communities, and the position is currently vacant at the moment. And our other community partners include Vancouver Coastal Health as our main funder, Fraser Health Authority, the Health Initiative for Men, and some other community resources that we partner with, like Boys R Us, Bathhouse Outreach Nurses, the STOP Team, Arise, Duke, the Downtown Eastside Women's Center, Dudes Club at Vancouver Native Health, Crosstown Clinic, and some HIM clinics. So what do we actually do as health promotion case managers? So we work towards HIV prevention, and we work at it towards we work within the micro, meso, and macro levels of HIV prevention. At the micro level, At the micro level, we kind of create behavior change by identifying and addressing risk factors. And some of these risk factors are the many social determinants of health, like gender, class, race, mental health issues, geography, a lot of things that really impact a person's health and well-being. So while working with our clients, we provide a lot of short-term interventions like rapport building, navigating different systems, counseling, connecting people with different resources, coordinating care, and goal setting. So these are some of the main things that we do with our clients. So it's a short-term program where we strive to work with clients for about 1 to 5 months, but really it's a very client-centered approach, and like the client really dictates how long they engage in the services. So at the meso level, it's all about creating community partnerships, and I think this is the most important part of our program, because when some risk factors go beyond our scope of care, we're able to refer out to many of our community partners, like Paul Perry working at the nurse practitioner working on the Huynh clinics, and Three Bridges for a lot of primary care needs, and also Lyndon Newdorf, gay men's counselor with the STOP team. So, and at the macro level, we're working with populations that are unable to understand, or working with key populations, we're able to understand the systemic barriers that make these populations key populations and why they continue to be key populations. So, and hopefully we'll be able to advocate and lobby for national health policies that address all these issues. That might be a lofty goal. And also we're hoping to address the many gaps in care. So the Health Promotion Case Management Program is actually the first fully funded intensive case management approach to HIV prevention in Canada. So it's been pretty great the last year, and I feel like we're doing lots of great work. So who is accessing care? At AIDS Vancouver, the Health Promotion Case Managers work with men who have sex with men. And what we're seeing is that our clients are still predominantly gay white men. And we recognize that race is not the only identity marker that impacts a person's access to care, as class, gender, and geography are other huge barriers for our clients. But for the purpose of this presentation, race will be the main focus of how the aspect of hierarchy within the gay men's community continues to present stigma and discrimination as a major barrier for men accessing supportive care. So my position was developed to reach out to the OMSM demographic, who are theoretically located in the Fraser Health and Vancouver suburban areas. However, stats show that predominantly white men are still the ones typically out there getting tested and accessing services. So in Fraser Health, I've been working with through the Huynh clinics, and just collaborating with Sam Larkin from Huynh. He kind of just developed some stats for me. And so at the Huynh clinics out in the Fraser Health area, it's still predominantly, well, it's gay men that are getting tested mostly, and they're mostly white. And what they're saying is that, you know, although that they're connected to to primary care, they're still a little bit uncomfortable about disclosing their sexuality to their doctors. And even people that are not connected with a family doctor, they're kind of saying the same thing. So what I'm seeing with my clients out in the Fraser Health area is that, well, 13 of my 37 clients identify as being people of color, and 7 of the 13 have cited racism as a barrier in the gay community. 3 of the 7 were born in Canada, and 4 of the 13 cited language as a barrier to getting tested and asking for help. And 11 of 13 cited low sexual health education. So Marcus is just going to provide a brief case study about what we're finding and how this kind of applies to the clients that we're working with.
So this case study is an illustration of the stigma and prejudices that our clients are facing on accessing the services in Vancouver. I also want to emphasize that I have the consent from my client to speak about his case, which of course I have changed most of the identifiers in order to honor our confidentiality agreement. So Bob is a 30 years old, deaf, self-identified gay man. He's of Asian background, lives with his family, and only his mother knows ASL. Although he knows English, he never learned Cantonese, and thus is unable to communicate with his grandparents. He lives in Coquitlam and mostly come to Vancouver to go to the bathhouses and needs to lie to his mother about his whereabouts. Bob also mentioned that he is not out to his family. He doesn't have friends, and the only people that he ever interact are those in the bathhouse, his mother, and people who he chats online. Bob has a family doctor since he was a child. The doctor doesn't like to write much in order to communicate with Bob. And when he does, Bob said that he can't understand his writing. So Bob came to the Huynh clinic and tried to communicate with the receptionist by writing. Since I was at the drop-in that night, the receptionist directed Bob to me. He had a writing conversation with one of the nurses at the bathhouse who told him that he should get tested for, he should get the HPV vaccination. Due to difficulties in the communication, he thought that he has acquired HPV. So at first, Bob was very frantic, and he had a lot of concerns about his sexuality, especially about acquiring HIV or STI. It seems that the conversation that he had with the nurse only increased his uncertainties around the ways that he was pursuing his sexual life. To communicate with Bob, I would book an interpreter through the Wellbeing Program, which is funded by Vancouver Coastal Health as well. He was aware of the services, but rarely used them because his mother has been very protective about doing all his translations. Bob finished his high school with a lot of internalized homophobia caused by his fellow classmates. When asked about his family doctor, Bob said that he doesn't feel comfortable talking to him because of his sexuality, and his mom always wants to go with him to the doctor appointments. During the intake process, he brought up a lot of concerns about his self-image and self-esteem. Bob said that when he's looking for sex at the bathhouses, people avoid him because of his looks. He also mentioned that the problem is even worse online, where the message is even more explicit. Guys are posting on their profiles, "No Asians." Since the very beginning of our meeting, Bob was considering eyelid surgery and as a solid option to change his racial identity. He made a lot of research on the topic and brought this issue in numerous times during our appointments. Bob explained that he has been shunned from the deaf community. He described that after an incident in high school, he saw many of his classmates gossiping about him and making jokes about his sexual preferences. He also feels excluded by the Asian community because there is an assumption that being gay is wrong and embarrassing to the family. These aspects only contribute to his isolation. He never traveled anywhere rather than Vancouver. Being shamed by parents, school, and the gay communities also increased his tendency of not asking for help and never accessing services. While talking to me, he kept on apologizing for taking my time, even after I had to explain to him that that was part of my job. So the first big issue that Bob was facing was the lack of access to specific services, such as the Wellbeing Program and interpretation services. Bob was reluctant because he feared that he would bump into someone of his childhood bullies. He took several meetings with the Wellbeing Program coordinator to convince Bob that he could trust them. Later, Bob wanted to discuss aspects of his sexuality, but he was afraid that the doctor would tell his mother about being gay. Working towards a solution, Bob agreed that he needed to have his own family doctor. So I connect him with the nurse practitioner at Huynh, and he started booking his own interpreters. Bob was really happy about this because he was finally able to talk about his healthcare provider that understood gay needs. He identified two specific problems related to his identity: being gay and being deaf. He isolated being gay from being Asian, despite indicating that he wanted to change his Asian identity markers because of negative attitudes from gay men. He wanted to discuss being gay and being deaf separately and agreed that having a deaf counselor would assist him on navigating through the challenges and stigmas of being deaf, while having a gay counselor would focus on his identities of being gay. Self-image and self-esteem. So since we started working together, I noticed that Bob had a hard time making decisions. He constantly kept on asking what to do and making decisions for him. Exploring this topic, it was evident that Bob had always been afraid of his decisions because he always been criticized by his choices. Since this topic were rated very difficult to deal with, Bob decided that the best approach was to start with the small steps, and making small decisions would be the best way to focus on the big picture. Bob has made a lot of progress toward meeting his goals of developing independence. In 1 week, he has begun the application process for the Gallaudet University, a school which specialized programs for the deaf community, and decided to visit universities in the US. He traveled alone and attended 2 different gay pride parades and made numerous connections with other gay guys. The next step with Bob are to further explore his gay identity.
So why is it so hard for kind of clients like Bob to get connected to supportive services? And why is it so hard for us as like service providers to connect someone like Bob to services? And why is race, language, culture continually barriers for people to access supportive services? So kind of looking at Bob's narrative and coming from a critical race perspective, race and his desire to change it through an eyelid surgery caused by Asian stigma within the gay men's community was a big underlying issue for him. Race, language, and culture have forced him to kind of covertly frequent bathhouses without his mom knowing and reluctantly accessing community resources in the fear of being spotted by bullies from his past, and also feeling like his issues aren't important enough to bother people with, forcing him to keep his identity kind of on like the down low and in the underground. Like the fact that people like Bob who need support aren't easily represented in the community, and gay white men are continually the dominant demographic accessing supportive services, reinforces the idea of hierarchy within the gay men's community. So, and hierarchy remains a dominant phenomenon that produces and reproduces the impacts of stigma and discrimination within the gay men's community. So just a quote from the Pan American Health Organization is that key to understanding this neglect and barriers to care and supports for MSM in general is the context of social exclusion and marginalization for MSM in which HIV and other health concerns are situated. Like to really understand the underlying reasons to why there is a hierarchy and why gay men of color experience great barriers to care, we need to really understand the historical context of racism and how it really relates to the gay community. So racism is the result of lasting and ongoing impacts of colonialism. It's created an irreversible hierarchy. So non-white, non-native English-speaking, non-status Canadians, non-settlers, non-Western educated, all these things continue to be the people who fall lower and lower down the hierarchy and are underrepresented in the community because they're not accessing mainstream services, as these services aren't really catered for them. So who is on top of this hierarchy? So looking at the idea of the ideal citizen, like this manifestation of the notion of the ideal citizen is kind of what's on top of the hierarchy. Like white, able-bodied, middle-class suburban men with families, probably a dog and a house, are arguably like the ideal citizen on top. And arguably, the same hierarchy exists within marginalized communities. So the closer you are to the ideal, the better your chances are at accessing services. And it's become accepted over the times. It's become quite evident in the gay community. And to understand this from a critical race perspective of why gay men of color are continually underrepresented, we need to understand the historical context of racism and how it's manifested in the gay community. So looking at the gay liberation movement and where it's come, so despite 3 decades of advocacy on the part of the gay communities around the world for appropriate legal rights and healthcare services, including HIV prevention and care, in most parts of the world, MSM still have little or no access to either HIV services or other MSM-oriented general health services. So what are the areas of the world that lack access to health, and who are they? So those areas of the world are reflective of the people who experience those barriers here in Canada and also in Vancouver. So if Canada experiences such great access to care, why is it mainly gay white men accessing care, and why is it so hard for Bob to get connected? To understand this, again, we really need to understand the gay movement through the lens of critical race scholars like Chon-Suk Han and Alan Berube as a shift from liberation to acceptance. So moving from liberation, from where we were like years ago in the gay movement, to where we are now for gay acceptance, I know these images are quite cliche, and like, why are these images cliche now? So the gay movement has really become about visibility through established institutions to challenge the mainstream, understand heterosexist bias against the LGBT community, which in theory is great, but it's become about promoting acceptance rather than liberation. Gay activists have needed to adapt to whitening practices to sell gay America, gay Canada, gay Asia, gay Africa, all these areas of the world to the heartlands of these areas. And mirroring the whiteness of men who run powerful institutions as strategy for winning credibility, acceptance, and integration, excluding people of color from gay institutions, selling gay as white to raise money, make a profit, gain economic power, and the daily wearing of the pale protective coloring that camouflages the unquestioned assumptions of unearned privileges of gay whiteness. So similar to how white men continually run our countries, white bodies continually manage gay men's health. And because of this acceptance, a monolithic perception of who gay men are has been created, and this image is what's catered to in our supportive care services. So I don't speak of whiteness as solely as just bearing white skin, but rather I adopt an understanding of David Roddiger, a critical whiteness scholar that calls whiteness a practice of how close you can get to pass as being the ideal citizen. So, and what really kind of sums up my experience as kind of a gay racialized male is something that my client kind of said a few weeks ago, and that speaking up and being ignored has come to be a common occurrence. So racialized gay men are there, and however systems are still in place that privilege other voices over ours. And the commentary and stigma of you're not gay enough on colored bodies kind of subverts us onto the lower rungs of hierarchy, prevents gay men of color from adequately accessing supportive care. So I'm running out of time. So these are just some conclusions that kind of summed up some of what we've been discussing. And I just want to go into what some of the things that health promotion case management has been doing to address these barriers. So we've continued to build strategic partnerships, like with the bathhouse outreach nurses at Steamworks, F212, and the Red Door. So working with people like Patrick Wansborough and Glenn Dupé, we've really been able to kind of reach out to lots of different clients. And also continue to work in the HIM clinics in the Fraser Health area. And also with the Dudes Club at Vancouver Native Health, connecting with like kind of men in the downtown east side who I think have kind of been overlooked. And also with some men who have sex with men who also attend the Dudes Club. And also Marcus is working at Boys R Us, connecting with men that used to be involved and are involved in the sex trade. And also the development of support groups. So I just developed the Queer Men of Color discussion group, and where we discuss issues of culture, identity, race, stigma. And the next group is actually today at 11:30 at the Gathering Place. So if anyone wants to join me, I'll be there. And also Marcus, myself, and Navi, the three case managers that work mostly with gay men, are using our lived experiences as gay, Chinese, Vietnamese, Brazilian, and East Indian men, and using our languages of Cantonese, Vietnamese, Portuguese, Hindi, English, and other case managers on our team that speak French and Spanish. So what more can be done? And it's almost come to a point where the lack of access to care for racialized gay men has positioned race as a risk factor for HIV and other health concerns. So we need to really continue to target systemic and institutionalized barriers for gathering information from data, and data from working with key populations to one day move them away from being key populations. And I think the most important part of this is to just really continue creatively building strategic partnerships.